Okay. Well, as I said yesterday, we know who is in, who is out. Yeah. We know who is here, who is out, and at what time. So last night, I got the list from the conference services. Today, I'm going to do the same. So please don't leave the meeting room if you. All right. Dear colleagues, dear friends, I hope that you had some evening yesterday. Anyway, Geneva is nice in the evening. It's also very safe, so nothing to fear when you are out in the night. Today we're going to look at two areas. One is on the training tools. The other one in the afternoon will be on surveillance issues. But I've put this slide just to allow us to focus also on the level of the health system where NTDs are normally implemented, hardly at the national level in terms of care, except referral cases. But most of the cases, if they can be detected early at the sub-district and community levels, that can also lead to early diagnosis and treatment. And then within the district health system, the district hospital often is the referral place for most of the cases. In terms of infrastructure and human resource, there is a bit of limitation depending on the development of a particular country. What may be applicable in Australia may not be so in Papua New Guinea. So let us take this into account also in what kind of materials, training, tools, surveillance systems that are needed for the health workers, particularly sub-district, who are mostly multi-task nurses and community volunteers who do a lot of many other things. We also need to think about community awareness materials that are integrated, training materials that are integrated, so that in practice, we can move away from single disease training, single disease surveillance, single disease this, into a more integrated approach. So I think this is all I wanted to highlight before we start today's session. Thank you very much. Steph, you can proceed. Yeah. Let's start.
Thank you very much, Kingsley. Good morning to everyone. My name is Esther Freeman, and I'll be chairing this session. First up, we have Dr. Claire Fuller, who's joining us from the International League of Dermatologic Societies and the International Foundation of Dermatology, and she'll be presenting on capacity building and tools for district health workers and community agents. Thank you, Claire.
Thank you very much, Esther. And once again, a big shout out to the WHO NTD department for conceiving and hosting this first of its kind meeting. It's not easy to change direction completely on the strategic enthusiasms of policy. And after 30 years of being personally involved in working within resource-limited dermatology, this is truly a campaign highlight. Thank you so much for the opportunity to present and kick off this great-looking lineup on training tools. I've listed a number of organisations that I'm connected with, and whilst L'Oréal pay my husband's salary, they have no influence on the content of this presentation. We're by now very familiar with the list of disorders that have some sort of skin manifestation, as well as the concept of integration, combining activities around two or more diseases at the same time in the same communities with an aim of increasing efficiency. And we've heard how there is a high burden of skin disease worldwide and a scarcity of dermatologists everywhere, especially in low-resource settings. Nowhere more acutely, and where we have data from, than sub-Saharan Africa, with several countries having no dermatological specialists and others having maybe just 1 per million for the population. So what opportunities do we have to capacity build in these settings? As we were challenged yesterday, it's impractical for dermatologists to be even attempting to deliver the care at universal health coverage level. Instead, we need to be smart about training and supporting health workers on the front line in basic dermatology through not only skin NTD hard copy materials, but innovative digital tools such as targeted apps and teledermatology. With the exponential increase in penetration of mobile phones per capita being well established, as shown by this red line, compared to the flattening off of the distribution of personal computers, as shown by the blue line, whereby more people have mobile phones than access to running water across the world, we have an opportunity to consider so-called leapfrog technological solutions, jumping over the traditional answer of training more specialists, which would fail to deliver the capacity in time to achieve the NTD 2030 roadmap targets. So how can we increase access through accelerated service provision and support? What are the opportunities to task shift and scale up dermatological skill and skin health knowledge amongst the frontline community healthcare workers? Can this enhance the prospects to increase data acquisition, leading to richer monitoring and evaluation information and enhanced research opportunities? Some of you will have been involved in 2021 with the Research Links initiative from Core NTD, our session focusing on improving patients' journey, looking at impact and efficacy of training tools for skin disease, trying to understand how we might know if they work. What are the lessons already learned that should be included in future scale-up plans? We explored various considerations needed for successful capacity building. In particular, noting it was important to identify who was being targeted for training, ensuring that this was specifically focused. On-the-job supervision of the newly trained healthcare worker was also recommended as most likely to embed learning into subsequent working practices. Measuring the behaviour change of the learner was deemed to be the way forward, as trying to show a reduction in incidence of NTDs would be unrealistic at this stage. And we reflected on development of surrogate markers to review and record behaviours such as making the correct diagnosis, prescribing appropriate medication, and referring onwards appropriately. Collaborations were also identified as crucial, such as involving regulatory bodies early to ensure that all learning was recorded and embedded in CME programs, and also involving community and local liaison, identifying patient leads and community volunteers, as this was most likely to enhance the impact of any program. In addition to those already mentioned, supporting learners with takeaway reference manuals of some kind and effectively credentialing them was also deemed essential. So what educational materials are already out there? Well, I encourage you to take a look at this poster, a review of the Skin NTD online training materials and diagnostic tools directed at frontline healthcare workers. The heavy lifting on this work was undertaken by Saba Lambert and Amna Elias, and they have catalogued and critiqued the limited materials available, ranging from atlases, mobile apps, posters and infographics, and online courses. Should we also perhaps be reviewing hard copy materials already out there that might be translated into online PDFs and so forth? Are there any other online courses apart from those hosted on the Open WHO platform that might be free or cost-effectively available to our target communities? The NNN Skin NTD cross-cutting group, led by Michelle Murdoch, Ree Yotsu, and Lisbeth Miras, is coordinating this work, and we would love to hear from you if you know of other materials, however rough and ready, that we can reconsider and adapt and repurpose and modify for different locations. So do get in touch. So thinking about the skills that will be needed to facilitate the community healthcare worker to access teledermatological opportunities in the broadest sense, what else will be required apart from dermatology content? Training on how to take a decent image with your smartphone that can be used to assist diagnosis, support teledermatology, and even contribute to the development of image banks to support the training of augmented intelligence algorithms is a key skill for the modern community healthcare worker. And I hope you got a chance to look at this poster, which practically teaches how to improve quality of images taken directed at the front line. It focuses on image quality, standard sets of images to facilitate skin diagnosis, and how to get the most of a smartphone. If you missed it, Nina, the first author, a medical student, is in the room, and she'll probably wave to you now. There she is over at the back, if you didn't get a chance. Well done, Nina. So we'll hear more later this morning on this issue, but take a look at this on-the-job support posters describing how to care for wounds, whatever the cause, bringing some universal standardized recommendations to the frontline healthcare worker, sharing 6 basic principles to address when managing chronic wounds in whatever situation. And finally, I want to share some experiences from the field. Kicking off with what has been learned from a long-standing partnership between Botswana Medical School, the University of Pennsylvania, and the Botswana Ministry of Health, delivered through North American dermatology residents over 15 years. What have they learned from the teledermatology and health informatics program? The first lesson, a requirement to be innovative, noting that to be sustainable and successful, they needed to involve key stakeholders early in the planning of projects. Building on the techniques to achieve sustainability, how do you design to be able to embed in local infrastructure? Solution by involving the Ministry of Health at the outset to ensure that the process of budgeting and prioritization is started early and committed to as the partnership programs are developed. And linking with local business giants were also particularly rewarding in the Botswana-UPenn collaboration. And how do you achieve effective evaluation and dissemination? By publishing successes and failures and challenges and processes in peer-reviewed literature, which assists in building academic capacity as well as contributing to the data informing progress. Be pragmatic. How can you get the best outcomes for patients in the circumstances available? This is most effectively achieved by meeting people where they are. And whilst the projects with Microsoft and Orange were rather brilliant, it was the pragmatic use of WhatsApp linking that provided ongoing clinical relationships required to support field care workers. A review of the WhatsApp platforms in these settings recognized it had its place with limitations, the main one being the lack of opportunity to easily integrate with the patient record, providing limited use for ongoing patient care and data gathering. Next up, teledermatology teaching, focusing on neglected tropical skin diseases. The Estrada family have more than 30 years' experience training in resource-limited environments in rural, hard-to-reach Mexico. Whilst initially undertaking outreach clinics, a combination of security becoming more challenging and then COVID led the team to look at other methods. And the teledermatology initiative commenced. A combination of teaching courses supplemented either by attendance at big one-day dermatology camps in remote areas where the course participants see cases alongside their teachers, or teledermatology consultations. A typical day-long training agenda incorporated common skin diseases as well as relevant neglected tropical diseases and how to navigate teledermatology platforms. And how do you cope in the context of political disruption and community violence? The newly established Burma Skincare Initiative was forced to innovate following the outbreak of civil war in 2021, which led to them having to move their support of their fledgling partnership colleagues to an online platform, Consultant Connect. With the platform licenses being negotiated for free, they were supported with a team of UK dermatologists, supporting not only diagnosis and management, but also professional and emotional support of the Myanmar dermatology team. So as we move into this session on training tools, we'll share some ideas on increasing access, increasing skill transfer and task shifting, and opportunities to increase data acquisition and contribute to research, as well as information to support monitoring and evaluation of our skin NTD programs. As I mentioned yesterday, considerable specialist support has emerged from the international dermatological community, with more than 30 dermatologists physically attending this meeting in person, and many others virtually from more than 20 countries, compared to just a handful back in 2019. We're delighted to see this initiative flourish, believing that skin health is global health, and we have much to offer and are willing to serve. Thank you for this opportunity.
Thank you very much, Claire, for that wonderful tour and idea of meeting the people where they are. In particular, a focus on innovations in the face of political unrest, which I think can be challenging for everyone when it comes to training tools. With that, next up we'll be having a Zoom presentation. Joining us live online, Dr. Ketese Beleta, joining us to discuss learning on the job for integrated skin NTD screening and care in Ethiopia. Optimizing resources by crossing boundaries of formal and informal education, looking at preliminary results. Recorded, excuse me, not live Zoom, recorded. With that, we will open the floor.
Thank you for inviting us here. Our presentation is titled Learning on the Job for Integrated Skin NTD Screening and Care in Ethiopia, Optimizing Resources by Crossing Boundary of Formal and Informal Education. Preliminary result. It will be a joint presentation from me and my colleague. My name is Buzayo. I am tropical dermatology professional specialist. I am from GLR Ethiopia, and I'm going to present the introduction, the rationale and the methodology part of the presentation. Let me start from the introduction part. Research is conducted on the prevalence of skin disease and associated morbidity in African countries indicates that there is high prevalence of skin disease, which ranges from 20 to 80%, which is higher than the overall prevalence of skin disease in the worldwide. In addition to this, there is a shortage of dermatologists by ratio, less than one dermatologist per 1 million population for most of the continent. And they are usually working in the private sector or urban setting. And there is inadequate number of dermatologists or lack of dermatologists in the rural area, which is one of the contributing factors for disease burden in the rural areas. To provide dermatological care for underserved community, it needs task shifting and disease integration. Research conducted on skin NTD mainly focused on the epidemiology, the prevention, control, and elimination strategy, as well as it mainly focuses on the opportunities and the challenge associated with this. Few researches few research were conducted that indicates there is a need to advance knowledge on both formal and informal learning process of healthy workers in the field of skin NTD integration. And this becomes especially clear if you look at the research conducted in Ethiopia that shows only 80% of the general healthy workers included was able to diagnose leprosy correctly. The other important part or points of this presentation is the PEP or LEP. PEP4 lab is to arm cluster randomized implementation trial in Ethiopia, Mozambique, and Tanzania. It is to evaluate integrated skin screening of leprosy patients combined with providing leprosy post-exposure prophylaxis. More about the project will be presented later this week. And one of the PEP4 lab research arm includes the community skin screening events, and it is also called the skin camp. In every skin camp, there is index leprosy patient for which skin camp is organized, and the extension health workers mobilizes around 100 contacts to the skin camp sites, and therefore they are screened. And the dermatologist, together with other healthy workers usually involved in the screening activity, plus provision of the post-exposure prophylaxis for leprosy. Besides provision of post-exposure prophylaxis, common skin diseases are treated with free topical medication. In case referrals are needed, medical referral papers are provided to the patients. The next patient identity is not announced to stop or to reduce stigma associated with leprosy. The second part of the presentation is rationale for the PEP4 lab site studies on the capacity and the healthy workers' acceptability. Before and after the start of the skin camp, healthy workers and extension healthy workers receive training on how to recognize leprosy, how to recognize skin NTDs, how to diagnose common skin NTDs, common skin disease, and how to use a skin app that helps them to diagnose and treat common skin diseases. In addition to this, it also look for if the community skin NTD screening helps the healthy workers and the extension healthy workers gain a new experience, how can this further be improved? In turn, this needs to understand on how healthy workers at different level exchange knowledge in their effort to optimize integrated skin screening in the community. This is one of the objectives of the capacity and acceptability side studies in this project. In case of the methodology, the studies in Ethiopia, in Eastern Ethiopia in January 2023, and the observation were conducted or take places in 3 skin camp by team from Netherlands and Canada, and the team from Ethiopia conduct an interviews with 10 healthy workers, which include dermatologists, healthy workers, extension healthy workers, the community volunteers, plus the index and the contacts. And the final one is the thematical data analysis is conducted, and which involves allocating core to data over series of cycles and looking for patterns and themes.
Thank you, Bial Buzayo, for your presentation on the introduction, the rationale, and the major part of this presentation. I am Gitesh Sape for Lab Project Manager for Ethiopia. I will proceed with the preliminary finding of this study. There was a distinct difference between the type of learning that was observed among different participants at different professional levels, especially for healthcare workers. And the dermatologist was mainly engaged in providing on-job training, coaching, mentoring health workers. The health workers in turn coached and trained the health extension workers at community level, mainly on organization and logistic issues. And the dermatologist by himself also learned from health extension workers and health workers about the challenges and experiences that they faced during working on skin NTDs in hard to reach areas with the existing limited resources and training. And here is a quote from a nurse. I have gotten experience and the skill on how to differentiate among various skin diseases, especially working with the dermatologist has improved my skill in the identification and the treatment of skin disease. Health workers and health extension workers stated that they had little exposure to dermatological conditions before the implementation of skin camps. Here is a quote from a nurse. I came across almost all skin diseases that I learned during my university education, and I have gotten experience and a skill on how to differentiate among common skin diseases, and working with dermatologists has improved my view and skill on the identification and the treatment of common skin disease. This was stated by a nurse during interview. The healthcare workers reported that they have learned a lot during the formal learning, and beyond that, they were coached by the dermatologist during the community skin campus. And the healthcare workers also stated that they need still refresher training to be able to provide quality service with respect to integrated skin screening, and also to be more confident and more independent, and to optimize their desire to serve their community and to conduct integrated skin screening also. Here is a quote from a nurse. And the dermatologist told us that you should practice also and have some exposure, and then you can also screen skin disease at your local health facility. And here the nurse is mentioning that now he is preparing himself to read necessary materials carefully, and then he should increase his skill and the confidence in diagnosing and treating the skin disease in his local health facility and in his own local community. And another quote from health extension worker is here. I want to become more professionally competent and to be examined for that, to increase my level to level for health extension worker, and then I can improve the service that I provide to my community. And actually, I was born around here, and I know what is existing in my community regarding the health problem, especially. This was a quote taken from health extension worker. And a central sub-theme of the study was the importance of healthcare worker training on care coordination beside clinical training. And here, the main point is that not only focusing on the basic triage and the clinical skills, but also focusing equally in the communication area. Like, for example, health education, stigma reduction, mobilization, and being able to facilitate the referral linkage between the community and the health center is very important, and it should get attention. This indicates most of the time training is focused on clinical training, and the communication part does not get attention, and so it needs actually equal attention because it is very important. The social part is very important. Mobilization is also very important. Here is a quote taken from one of the health extension workers who participated in the interview. I have participated in 2 skin camps and the community mobilization, and I knew a few skin diseases like fungal infections. And I learned a lot today about how to give health information to the community, especially by mobilizing and bringing the community in one place and then disseminating different information at the same time at one place is possible. And the health extension worker is stating like that. And she also told the people in the community today to keep their personal hygiene and also to attend the skin camp. And she told this and during the mobilization for 2 days skin camp. And whole health staff shared that the project motivated and impressed and inspired them to work with skin and NTD in communities by getting experience and learning about the advantage of integrated skin disease, especially during skin camps. Here is a quote from a nurse. Today, at this site, the dermatologist showed us how practically to screen and examine the skin of patients. And after I go back to my team, I am going to prepare myself better for diagnosis, and I will read the existing standard operating procedures and the guidelines that can help me to diagnose existing skin disease and then apply them to my local health center. And another quote from a nurse stated that when I heard about the skin camp for the first time, I was thinking that the screening is done at facility level. But when I participated in this camp and observed the existing situation, I recognize that if there is a commitment, everything is possible, and the outcome is far better than waiting for the patients at health center level. This means the nurse is recommending that going into the community for integrated skin screening and management is better than waiting them at facility. Yes. And here is a conclusion, preliminary conclusion. The study shows that the value of understanding processes as well as outcomes of learning in skin neglected tropical disease screening and care and skill transfer are also important for settings outside Eastern Ethiopia. The other part of Ethiopia should also consider this one. Even the other part of Africa or the other part of the world may also consider this issue. This is the conclusion of the study. And the results indicated the importance of sufficient attention for formal learning, situated learning, fostering training in cross-positional learning. Very important stated. Here are some take-home messages. Investing in both formal and informal learning is important for the successful service that will be considered with the integrated skin screening, and the task shifting can also be considered. Learning should not only focus on clinical topics, but it should equally focus also on software, on soft skills such as communication and logistics. They are equally also important. Most of the time, our health workers, our health system focus on clinical topics, but the soft skills like communication and logistics, they lacked attention. So they also need equal attention. And when doing this, the actual local context should be taken into account. And further research is actually needed on how to increase the impact of dermatological training in the existing challenging settings, especially if upscaling integrated skin screening services are planned. Finally, we would like to thank all the study participants, including the index patients, the leprosy contacts, the community members, health workers, PEP for lab consultant members, and the project donors and the funders, EDCTP, European Union, Leprosy Research Initiatives, DAWI, GLRA, and our special thanks also runs to the drivers who worked with us during the data collection and the field visit. That was our presentation. Thank you very much. Questions are highly welcomed. You can comment. Thank you very much.
Thank you very much, and really wonderful experience in the field in Ethiopia. Thinking in particular, as we know from yesterday's discussion, that dermatologists are not themselves going to be able to see all of these patients at frontline. So thinking about how do we task shift, how do we focus on process, and how do we also think about the soft skills such as communication that may not be immediately apparent that that's what we're working on when we task shift, but I think that's the combination, all of those things. So I think incredibly helpful to think about how these lessons from Ethiopia can potentially be applied to other settings. With that, we're going to welcome Maria Kano, who will be talking about the quality of the WHO Skin NTDs app and its use in Ghana and Kenya.
Hi, everyone. My name is Mireia Cano, and I'm a research assistant from the Universitat Oberta de Catalunya. And I'm going to present today our cross-sectional study when we assess the quality of the World Health Organization Skin NTDs app as a training tool in Ghana and Kenya. So first of all, and even it's really boring to describe terms, I think it's really important to define mobile health as an application of wireless technology, such as mobile phones, to the provision of healthcare. It is regarded as a component of e-health, which also refers to be secure and cost-effective use of information and communication technology to assist the health and disciplines related to health. With this, I want to point out that already 2 years ago, the Regional Committee for Africa of the WHO stated that mHealth is the most widely digital health technology used in this region. And despite we all know the great opportunity that brings us digital health, we know that Africa is not an exception, and there are multiple overlapping solutions with limited focus on scalability. Afterwards, I'm going to talk about it, but I'm not go deeply in that, but one of the main problems that we have nowadays is that digital health solutions are not correctly being assessed. Additionally, and in the other hand, pointing out again the importance of the roadmap released by the WHO in skin NTDs. Also, they point out that mHealth is really important. It's really important for managing and tackle the skin NTDs, and also as a training tool. That's why the WHO Department of Control of NTDs decided 2 years ago to digitalize the guide training tool, the guide training document that they released in 2018, and convert it into an app for the frontline health workers. Here you can see some screenshots from this app. Currently it's the version 3 that we have assessed, but you will see that really soon the version 4 will be released. This version is a combination between the Skin NTDs app and the Skin app from the NLR that the speaker before talked about it also. And this version includes not only a list from the skin NTDs, but also other skin diseases, like general ones. Here you can see that it's quite easy to use. The person who, or the user of the app, they only have to select the body parts where they can see the signs and symptoms, and in the next, the app, the next slide, they have to click on the signs and symptoms that they see on the patient, and the app came up with the most probable disease that they have. However, no evaluation has been conducted in this app. And we know, as I already mentioned, that the guidelines, they highlight the evaluation phases as one of the most important ones. Following this guideline from the WHO, many of us, before knowing that, but many of us will think that the first thing that we have to check is the effectiveness of the intervention. But rather of what we think, the WHO point out that the first thing that we have to assess is the usability and the feasibility of these solutions. That's why our main objective was to assess the quality of this Skin NTDs app as a training tool in Ghana and Kenya for frontline health workers. For doing that, we divide the study in 2 parts. In the first part, we sent a survey to our participants where they had to fill the user mobile app rating scale. This is a validated tool to assess mobile health apps. And they include 4 objective domains: engagement, functionality, aesthetics, and information, and 2 subjective ones. And that one includes the app specific, where they can answer questions about the impact that they think that the app will have. And afterwards, we conducted semi-structured interviews to don't miss any kind of data that the participants want to share with us. Here you can see our main common interviewee. We collect a lot of data. I'm not going to show it everything to all of you, but our main interview was a man from Kenya. I present you Dr. Kibaki. He's a frontline health worker, and he's between 36 and 45 years old. He lives in a rural area, and he works for a public setting. He's not trained in skin NTDs, but he states that he has some experience with dermatology And he told us that he deals between 1 and 3 times per month with skin NTDs. He also said that he had high knowledge in mobile technology, and the most important part, he had no training in skin NTDs in this skin NTDs app. When we checked the data obtained from the Mars questionnaire, you can see here that the most of all of these domains obtain more than 3.6 out of 5 points. So the app, the overall, they obtain a good punctuation. Here you can also see that the worst rated domain was the engagement, and the best rated one was the information. And when we did the comparison of the variables, this was really important for us, because when we compare the main variable that for us was the objective mean quality score, when we compare it with our main variables, we saw that there was no statistical difference when we compare it with age, gender, type of health worker, country, work context, frequency of dealing with skin NTDs, or dermatology experience. Also, we conduct a linear regression model, and we obtained that there was not significant difference. That means that no variable is that we cannot predict the result of how they were going to punctuate the app, regardless of any variable. And afterwards, we conduct the semi-structured interviews. We did it only with 5 participants, but more or less you can see that we obtained them basically really similar answers of what we obtained in the survey. You can see also that the best parts of the app were that it was really good for people without the skin NTDs experience, easy of use, friendly interface. They really point out that it was really nice that it was an offline, since a lot of them in the rural areas, they don't have good connection to the internet. And also some ways to improve the app. They said that there were still some customization aspects to work on. They missed an expert panel to talk directly. And also they told us that some notification and aesthetic changes in the app could be nice to use it better. So what we have here, we have that the skin NTDs app, it's good rated, but we still need to work in the engagement domain, mainly because most of them point out that they would recommend the app and use it more than 10 times per year, but then we have to make it more engagement. We have to work still in the engagement. I don't want to finish this presentation without talking about all the challenges that we face. So as you may know, I'm from the Universitat Oberta de Catalunya. We are based in Spain, and we conducted all this study online. It was really, really difficult and really challenging, all the recruitment part, and it could not have been possible without our local leaders. I know that one is here, and I really thank you, all the work that she did. And also the semi-structured interviews that we did it synchronous, online, in Teams. It was quite difficult also to perform it. But as a conclusion, we can say that this app obtained a good usability and user experience report. It was the first of evaluation, so we really need to work still. The results will be used to make recommendations to improve the upcoming versions. Some study limitations should be considered, and if someone has questions, you can ask it afterwards. And the future lines, now it's a moment to check the effectiveness, as you saw in this World Health Organization monitoring and evaluating framework. And also, if you remember what I have said, there were no difference between age, gender, country, etc. So that was the most important result for us, because it means that this app can be disseminated across all countries, of most of the countries probably, with skin NTDs, because it means that we don't have to do major changes in this app, and we don't have to create more and more solutions that they will overlap between each other. So as a main message to bring home, that you should bring home, I want to tell you that the use of mobile health is likely to improve the management of skin NTDs. The Skin NTDs app is one of the few app-based intervention in Africa to tackle skin NTDs. I know that before my colleagues also talk about it, and afterwards there's another presentation of another digital intervention. But also I want to let you know that the importance of the evaluation increase the likelihood of success. So thank you very much, and I want to acknowledge all the participants that they did a really great job. Esther, that she's here, that she was our local leader. Universal Doctor, that they were the ones who developed the app. To the WHO, that they trust on our group and our research group to do this job, and many other people. So thank you very much.
Thank you very much. Important to think about how we're going to be using this app going forward. And I think, as you mentioned, multiple overlapping solutions. I think also highlighting, what we'd heard in the prior presentation about the importance of ongoing training and ongoing connection rather than just a one-time thing. And I think the app is certainly a way that can be achieved. So thank you so much. What an incredible work. And I think particularly highlighting the importance of your local partners. So thank you very much. Next up, we have Ryatsu, who will be discussing also use of the mHealth app, a different app, the eSkin Health for early detection and case management of skin diseases, a mixed methods pilot study in Côte d'Ivoire. Ria, the floor is yours.
Thank you, Esther. So today I will be talking to you about the use of the mHealth application or the digital health tool, eSkin Health, in how we can improve early case detection and management, and also at the same time training on skin NTDs and other skin conditions in the context of Côte d'Ivoire. And so this is an example of how the skin integration can happen. As an introduction, I am presenting this slide, which shows that our past and present approach. We used to do skin surveillance through school-based survey and community surveillance and sensitization, which this was our previous approach. However, we see in this gap that even we detect a case of skin NTDs or other skin conditions, that many of these skin conditions need case management. And then we don't know what happens to these cases when we just go to the field a few times a year. And also, even we are not there, the cases are there, so there has been delay in diagnosis. So how to fill in this gap? And we came up with this application called the eSkin Health. And this helps as year-round surveillance and also the case management. And so we've integrated this digital health into our surveillance. This is our new approach. So what is eSkin Health app? I'm from Japan, and in Japanese means good, so literally means good skin health. And this is a collaboration between a Japanese app company that we've been making this development. Usually, when I explain about this device, I say that there's two functions to this device. One is that this can be used as a portable patient chart, and secondly, if the local healthcare providers need some support in diagnosis or case management, they can be connected to a remote dermatologist. So this is the two-way application that you can communicate also. So that's the difference between the previous app that has been introduced by the WHO and the NLR. It also has the offline function for remote to use, and then addressing the poor internet connectivity of these remote places, and also it can be used for any skin conditions. It allows documentations of patients' clinical course over time with the clinical data and also the images which automatically can be organized in chronological order. Also, you can enter lab data. So for example, for biliary ulcer, when you do the PCR and bring back the samples to the city, many times, oftentimes the result does not go back to the peripheral local healthcare workers or to the patients. But with this application, when you enter the data into this platform, these people also get the diagnosis, the PCR results, lab results in a timely manner. It also has automatic translation because not all the remote dermatologists can speak the language, which in Côte d'Ivoire is French. So recently, we've completed this pilot project for evaluating the use of the eSkin Health app to assess the feasibility, usability, and accessibility, and also the impact of the eSkin Health app within the skin surveillance approach. The study site was in the center of Côte d'Ivoire called Sanfra Health District, and 8 nurses and 16 community care healthcare workers were recruited, which were divided into intervention and the control arms. So what did we do to do these 2 arms? Well, we did all the things together, the same things, except for the intervention, we gave the tablet with the eSkin Health app inside and also the training using the app. Besides that, we did all the things the same. From the training on dermatology, we've trained them on the 5 targeted skin NTDs, also the basic dermatology, and also the clinic-based training, so bedside training by the dermatologists. Also, we've trained them on the photo taking of skin lesions. Initially, the idea was we are not going to give the device to the control arm, but since we provided the training to both arms together, and the control arm was seeing this other intervention arm was getting all these fancy tablets, they got jealous. So in the end, we did also provide them with a smartphone and train them on how to take the photos, and also, but after taking the photos, that they need to organize them so that we can also evaluate. And monthly monitoring visits were made. These are some of the results. Cases with dermatological conditions. You can see that in the intervention arm, we had a significant increase in the number of the skin NTDs diagnosed. However, it's interesting to see that actually in the control arm, these data were taken from the patient registry booklets, so paper forms. But we saw more cases of skin diseases listed there in the control arm, meaning that there are a high burden of skin diseases in these communities. However, many of these conditions were only documented as dermatosis, meaning skin disease, and the diagnosis was not given. Whereas for the intervention arm, the diagnosis was put with the skin conditions. So we have seen a definite impact of our intervention. This is also showing the diagnosis in the intervention arm, that the same diagnosis here, meaning that the nurse's diagnosis was confirmed by the dermatologist. And this was seen in 26% of the cases. And this can be an indication of the impact of the training that we had. Also, the diagnosis of 20.3% were supported by dermatologists remotely, and another 27% were done on-site. For the diagnosis that were done on-site, this has been for multiple reasons. Sometimes the images were not uploaded to the platform, even because of the poor internet connectivity, and the image size can be sometimes, if multiple, can be large. Also, skin conditions such as subcutaneous lesions, which was difficult to diagnose just by the photos and the clinical information. So these were some of the challenges we had for the remote diagnosis and the cases that were diagnosed on site. And also the median days of entry to diagnosis by dermatologists were 21 days. So we also have a referral function built in the eSkin Health app. And involvement of community healthcare workers with the app was measured, and it was successful in improving the referral rates to the PHCs. Distinct differences was observed between those who used the app to make the referrals and who used only the paper forms. And also it was very difficult to evaluate for those who only used the paper forms. System usability scores, SUS, is a standardized assessment tool for measuring usability, feasibility, accessibility of digital health tools. And above 80.8 is considered as excellent. And at week 3, we achieved this 86.3. So it took some time, but we were able to achieve this success. We conducted semi-structured in-depth interviews. Of course, we cannot present all the results here, but these are some examples. The benefits were felt both by the nurses and dermatologists. They were satisfied with the app, that they can be connected. It was interesting to see that the community healthcare workers, they were also satisfied by our project, but their satisfaction more came from being equipped with a tablet and an app, and this increased in confidence of doing their work. A quote, "I'm better considered in the community than in the past. When I communicate and I take photos using the device and I keep them secret, people approach me to tell me what they have." And they've also mentioned that some of their neighbors even, they did not know they had the skin NTDs, but with the app and this being in the project, they discovered these things. And on the other hand, the challenges were, even though we make this application used to be offline as much as possible, this is still a challenge. And so, like for instance, the uploading the images, we are improving on it, but it's still being a challenge with the poor internet connectivity. Also, we chose tablets over smartphones because of the information, the amount of the information we need to put in the tablets. But they felt the tablets are too heavy, big, and also the smartphones, they have really nice camera functions nowadays as compared to tablets. So these were some of the comments we've heard. Other challenges were such things as patients' access to PHC and etc. that we also see in other circumstances, not specific to our project. And our project really helped in empowering the local healthcare providers. And this is quote from a nurse there that I used to write dermatosis as diagnosis for all skin conditions. But with the app and the training, now I'm able to write good diagnosis. Patients are happy because they know there is a dermatologist who is a nurse called Behe in Konofura. So they'll really be happy involved in this project. So summarizing the challenges, the application was developed to be capable of offline usage, but still face difficulties with poor internet connectivity. It depended on the location of the users, and also the guideline for the teledermatology says that the image size can be lower than this, but also for further use of the images, we did not want to reduce the size, so this is what we are keeping, but doing other technical things to address this challenge. It needed around 2-3 months to get for the users to get familiar with the system, but we don't think this is a long time because it's also we are asking a behavioral change to these people that's taking the medical record of their patients. So we don't necessarily think this is a long time, but we are trying our best to make the entry as simple as possible. More skin conditions were reported from the control arm indicates the workload of entering patient data in the eSkin Health, and also we don't know the accuracy of the diagnosis in the control. So the table that I've shown is just for assessment of this study. Interestingly, the SADs were diagnosed, reported from the control arm, which were not registered in the eSkin Health because of course, the region area is a very sensitive area to take images. Taking patient medical record was new to many nurses, and follow-up data was not adequately obtained. So this application can be used for follow-ups, but so we would like to reinforce this usage more. Conclusions. Integrated skin surveillance approach plus was successful in identifying more skin conditions, skin NTDs, with very limited previous reports, and also with very limited previous reports and providing diagnosis to various skin conditions. And on the slide is showing a case of cutaneous leishmaniasis and mycetoma that from Côte d'Ivoire, there has not been many documented cases earlier. But using the system, because you document these cases, you can identify and report these cases. Digital health tools like eSkin Health facilitate screening, diagnosis, and management of skin NTDs and other skin conditions. Teledermatology is becoming a more common clinical practice in Western countries, especially after COVID-19 pandemic. However, the needs could be more in remote communities of low and middle income countries where skin NTDs are endemic. And they should not be left out of this emerging technology, and where this is improves access to care largely. The project as a whole contributed in building capacity in diagnosis and management of skin NTDs and other skin conditions in our study site. And we hope in other areas as well. Future directions, aligning, so we plan to align, we would like to align with the national data collection to ensure country ownership and sustainability. To sustain the system, we have developed a non-profit organization to host the app, extending our reach to other countries in the pipeline in Tanzania, where there is the regional dermatology center there, and building evidence. We are continuing with more trials, so data collection is even now ongoing, and more innovation is happening. And so this was outside of my abstract, so I did not present today, but image analysis, deep learning is going with the images that we collect. So I'd like to acknowledge all the people who's in this team and also in the room today, Professor Bagamon and also Professor Dayabidi Almami, Oben and Gontran has been doing the field work, and also the fundings that we've gotten. And also thank you to the National Blue Author Program and the programs for all their support that they provided to us over the years. So thank you.
Thank you so much, Dr. Yatsu, for that excellent overview. I think it's so important to think about how an app that was potentially initially developed for NTDs truly can be used for integration and for other skin diseases as well. I think another point that you highlight is the offline connectivity, because some of the questions coming through are about, that we kind of, I'm going to give you a preview so you can think about them while Dr. Postigo goes, is to think about what do we do in areas that don't have connectivity or internet. So thinking about how do we use these apps, and I think that's something you spent a lot of time thinking about, Dr. Yatsu. And also just a quick reminder for anyone in the back, I know sometimes there are issues hearing, I just wanted to remind you that your headset can be used not just for translation, but also just to hear, even in the original language of the floor. So if you are at the back and you're having issues hearing, just remember that you can use your headset as well to access the floor voices. And I have to say, no one's given me the chance to use the gavel. You know, I'm ready, but everyone's doing such a beautiful time of staying on time that I haven't even gotten a chance to use it yet. So, all right, well, with that, I would like to welcome Dr. Postigo to the floor. He will be discussing, although in some ways a man who needs no introduction, but he will be discussing WHO skin NTD tools for capacity building on case management and surveillance. And with that, I will pass it over to you.
Thank you, and hello to everyone. The presentation is being uploaded.
And while it's opening, I'll just remind everyone that the online chat is open. It was closed for a little bit this morning, but it is currently available. Although also in the Q&A session that will be coming up, you can wave your placard in the air and we will try to come find you. Apologize in advance if I don't see you, but just as a reminder. And the other just quick note while we're waiting for Dr. Postigo's presentation is that we do have the Director General photo today. I know all of you dressed up. Everyone looks absolutely beautiful. And so we will be ending our final session a little bit early at around 11:40 or 11:45 to make sure that we can go outside and do our photograph.
No problem.
While we're waiting for the presentation, I'm going to share one of the online questions that we can start thinking about. This is a question from Nigeria. Sarash Jamil asks about mHealth being a useful solution for skin health, but one challenge is reaching communities where there is no internet or where there is no electronic device available. And there are hard-to-reach health posts, and thinking about what alternative solutions can we have that don't require hardware. So while we're waiting for your presentation, maybe I can open that up to Dr. Yatsu and also Dr. Kano to think about how you would respond to that question.
Well, the version 3 from the Skin NTD app, that is the one that belongs to WHO, currently is working with an offline algorithm. So this thing is already solved. However, when we conducted the semi-structured interviews, all the participants, they state that they would like to have an online one. So I think that it could be solved. There are some apps that they can be used offline, and when they reach a Wi-Fi or a connection, they send all the data, so this could be a solution. But is something that we have to think about it. Actually, with the version 4 that Dr. Postigo is also aware of that, there are some questions that there are some advantages and disadvantages using online or offline softwares.
So, of course, there are challenges, and then some of the users of our app needs to travel, or we do have a focal person who can support to bring the device for the technology to connect to the internet. So yes, that's still a challenge. But what we've seen is that over the years we've been doing the project, the internet is just reaching the places where we did not see the internet connectivity. So it's an issue, but maybe it's an issue that is not going to be an issue in the near future. So, and we should not wait for this to develop things.
Well, can I just respond to that? Because my understanding is that you can populate the app offline, you can populate your platform, and you just need to then get to a Wi-Fi area to upload it. Mm-hmm. So it's still very usable, even offline.
Yeah, so it's just for the teledermatology aspect that you need to have internet connectivity for this application that I've introduced. So yes, so there's, depending on your needs, you can modify with the technology your digital health tools.
Yes, I think another important observation is when we look at the hard copy, the PDF, the book, the guidelines, the training manuals that WHO usually publishes, or this one on skin NTDs, how many copies can we print and disseminate around the world? The cost of that, the logistics. So if we go to any health facility where there is no electricity, are there any books there? Is the book in a format that you can have it in your pocket and in front of the patient you will use it? So in my opinion, and what we have seen is that having something translated into a mobile app is part of the solution. So for thousands of colleagues, they will have a mobile phone. When it is offline, they can use it with a couple of clicks. They get a list of potential diagnoses, and if they don't know about that disease, they can click and see what it is. And I liked very much the example that Rie shared. Cutaneous leishmaniasis is a disease that is largely unknown or underdiagnosed in West Africa. So you see, through that, we open a window. It's far from perfect when you need internet connection. But in the case, for instance, of Côte d'Ivoire, I was amazed 1 month ago to go to places that you need 10 hours by car, but still in the middle of nowhere there was electricity and there is internet. So, well, the health sector cannot fix the roads, the access to running water or drinking water, internet, but in places where it exists, I think it's a quite cost-effective solution, and it's one more tool. And this is not to replace the knowledge of an expert, a dermatologist. It's just to bring that knowledge from the experts to the first-line colleagues, dealing with the day-to-day problems.
Thank you so much. And I think with that, Dr. Postigo, I've gotten word that your presentation is available. So. The floor is yours.
Thank you again. Okay. So, as you know, capacity building and developing training materials is a key role, a traditional role of WHO. I will talk about 3 tools that we have developed: the online courses, the mobile app, and others that you are going to see now. So the OpenWHO is a channel, is a portal that WHO created back in 2017. At that moment, it was only restricted to the emergency department. But as of December 2022, it has 7.6 million people registered. It has over 200 courses on different topics. Next. And it delivers courses in 65 languages, so far beyond the 6 UN languages. Then in 2021, our department, the next one, our department was allowed to have the neglected tropical diseases channel, where you can see that we have several courses related to the skin, but not only that, we have also courses on cross-cutting issues such as medicine safety, supply chain, also courses dealing with One Health like rabies. Next, please. Next slide. And we have courses dealing with One Health. No, don't move until I tell you, please. And this is to test my level of stress. So we have courses dealing also with the One Health. It was one of the requests yesterday. And we have 3 courses related to the NTD framework and the roadmap. So in total, we have 22 courses, because here it says, 42. We have 20 original in English. Some of them have been further translated into Arabic, English, French, Spanish, Portuguese, Russian, and Hausa. But you see here 22 because half an hour ago, the course on tropical dermatology is now available also in Spanish. So in total, the NTD channel has over 85,000 learners enrolled on all NTDs. Next, please. So for skin-related courses, we have specific courses on disease, on a single disease, leprosy, PKDL, YOS, but we also have courses that tackle dermatology, like the course donated by the University of Minnesota, and we have a course also on podoconiosis, a very important public health problem in Ethiopia. In total, we have 11 courses on skin issues. Next one, please. Next slide. Yeah. We have courses on onchocerciasis, borreliose, and also NOMA, a very important disease, and the NOMA community has applied for it to become an NTD. Will know this decision at the end of the year. So as of mid-March, we had over 30,000 learners enrolled on skin-related courses. We still have 4 in the pipeline. We have slides almost ready on cutaneous leishmaniasis, lymphatic filariasis, and both superficial and deep fungal infections. So how is that possible for a team, a department that has not enough funds? So this is possible thanks to the volunteer contribution of over 100 experts worldwide that have been kind to donate their knowledge, their slides, and then the WHO team has arranged them. But thank you again to all of you, and several of you are in this room. Next, please. So let's analyze a bit what we have learned from those courses. First is, are we reaching the targeted audience? Are we reaching the countries they are meant to, or colleagues that live in areas that are endemic? So on the graph, in the left side of the slide, you have the top 10 countries from where people enrolled as of October last year. So mainly India, China, Nigeria, Pakistan, but interestingly, countries that are not in the tropics, that Azerbaijan are keen to use this channel. Also colleagues in the USA or Mexico that may not have a high burden. Then we did another analysis. It's like, well, when you look at the course, for instance, of post-Kala-azar dermal leishmaniasis, so, well, this is mainly prevalent in Southeast Asia, in India, Bangladesh, in East Africa. So if you have almost 1,400 people enrolled, you say, wow, all health workers in those areas must be enrolled in the course. But no, then you see that you have people from the USA up to China, and only 82 people from East Africa actually enroll. So we have a dashboard that allows us to know the age, the gender, the profession of those people, the country they are in, so that we can discuss with colleagues in the countries and the course owners whether we have a good dissemination strategy and whether we are really reaching the target audience. Next, please. We also did some analysis on the uptake depending on the language. It's quite an effort to translate the courses on several languages. So we can see in these 3 pie charts on NOMA, scabies, and twengiasis that most learners have chosen or have enrolled in the English version, from 54 to 75%. So the English version is highly, let's say, successful, and we need to continue publishing in English. Then when we look at, for instance, French in NOMA or Spanish in twengiasis and scabies, it's around 20%. So for us, it's a question mark, and we need to think further why, when we go to languages like Portuguese, French, Russian, in some courses, it's below 10%. Next, please. We also wanted to assess what those who did the course, what they thought about it. So we have a questionnaire, an online questionnaire, a survey with some 20 questions to assess what they think. And here I just picked a couple of them. So the first question is, this course met my learning needs. Are we doing something meaningful for people? And we are pleased to see that for 76%, they fully agreed on that, and another 15% somewhat agree. So let's say that 90% of those who answered, over 3,000 people, they were satisfied. And then another concern that we had is whether we are using the right language. Are we using a language that is too sophisticated for them to understand? And again, we are pleased to see that around 90%, they fully or somewhat agree that we are using the appropriate language. Next, please. So now let's move to the mobile app. Next, please. Yeah, this was done in 2020 when we translated the manual in the 4 languages, and we translated it into a mobile app. Next, please. This is the version that Mireia was talking about. The only thing I would like to add is that when we did the app, it was very easy for us to update the content. When you have to update a book, it may take 6 months, 1 year. When you update an app that is online, within few days or weeks, you just go to the back end and update it. And we were able to add something very interesting that you cannot get in the book, which is the global index. So you can choose the country where you are working or the country where you think the patient comes from, and then the app will automatically select the skin NTDs that are endemic in that country. Next, please. So thanks to colleagues in the Netherlands, the NGO Until No Leprosy Remains, we discussed and we say, well, WHO has done an app on skin NTDs, but we know NTDs are basically less than 5 or 2%, so you have a big gap. So they were very kind and we worked together, so we copy-pasted their app into the WHO app so that we include now common diseases. This is a beta version. Hopefully you will have it in your phones within a month. We are just double checking and fine tuning some of the content. Next, please. So here is the list. You will have access to the presentation, to the recording, but when we talk about common skin diseases, we are not talking about 500 diseases, we are talking basically about 25 diseases. And again, the good news is that 48 hours ago, we did another update. We received a file from colleagues in the Netherlands. So now folliculitis, keloid, norma, and urticaria are added as of 2 days ago. Next, please. But we wanted to move forward with times. We hear a lot about artificial intelligence, augmented intelligence. We know there are companies who have developed very powerful tools on that. But again, when you go to dark skin, when you go to NTDs, maybe there is not enough in the market. So in collaboration with the Universal Doctor, we incorporated a feature. It's also a beta version. We now have 5 diseases. We have trained the phone on 5 diseases. And these are Buruli ulcer, cutaneous leishmaniasis, Jos, leprosy, and PKDL. And this is just an example I picked a few days ago from photos that colleagues in Australia and Gabon shared with us, where you can see, of course, in a presentation, you will put the successful and the photos that work well. So it identified the ones, the actual diagnosis. Next one. But not all that glitter is gold. And there are bottlenecks with artificial intelligence, as it happens with teledermatology. Well, first, you need an internet connection. Without internet, you cannot access the photos in the cloud. And you need hundreds of photos to train the machine, and you need to have photos not only of several diseases, but also the different presentation of the disease and from different countries. So for that, WHO launched a global network in November to try to get a global photograph database and conduct field assessments. Next one, please. How we think we could further improve the artificial intelligence algorithm. And let me illustrate it with the case of YOS. If you look at YOS, we know that most cases, most lesions appear in the legs and the feet. The peak age affected is between 6 and 10. So if you have someone with a lesion in the abdomen and is 50 years old, the algorithm should tell you that that is basically very unlikely. Next, please. But if on top of that, we add the country, the list of endemic countries, where if you are in Congo, if you are in Cote d'Ivoire, still the disease is possible. But if you are in Spain, in the USA, or in other countries, the app should say that is basically 0% chances that that disease is yours. Next one, please. And the last thing I wanted to talk about is this system that we have, the DHIS2 web-based surveillance system, is the system that we use in WHO to collect data on several diseases. It's not the only one. It's also used in many countries in Africa for national surveillance, but that doesn't mean that countries must use that one. Next one, please. Out of the 13 diseases, click several times, please, until all the circles are there. Click quickly. Out of the 13 diseases in the Global Health Observatory, only 4 more, please, have data on number of cases and 2 diseases on control intervention. So next, yes. Next, please. So since January, we are in touch with disease experts, countries, and regions to see how we can add these missing 8 skin NTDs in the list for having patient-based data. Next one, please. The most important slide is going to disappear. Next, please. So, action points, reflections for us within this week. So, on online courses, I think WHO should continue creating and publishing courses on missing topics, and for that we are also having a meeting this week with colleagues in ILDS to see how we can populate and add more topics. We need to discuss with colleagues in the regions and the countries why it seems that when it is not English, the uptake is lower. Is because we are not disseminating. Why? We also need to assess whether the courses are really reaching the targeted audience, our colleagues dealing with patients or dealing with national programs. As regards the mobile app, we hope to publish, to make it public, this new version with common skin diseases in the coming 4 weeks, and then to improve the augmented intelligence algorithm with photographs, and in both cases, to do this field test. On DHIS2, and I want to emphasize that countries are free to choose their surveillance tools, we will just convert the Excel files or whatever format into what WHO is using now. We should include all skin NTDs in the forms that are in Access 10 of the framework. And then we should train clinicians and data managers on the skin NTDs that are relevant for a given country. Thank you.
Thank you so much, Dr. Postigo, and he's just been an incredible collaborator for us in the skin world in terms of your opening and welcomeness to all of the online courses, and just incredible work as you think about the challenges of truly scaling up. And I love how you're really focusing on, what can we improve? How can we make sure that the courses are actually getting to who we want them to get to, rather than just looking at the pure numbers? So I think just incredibly important points there. With that, I'm going to open it to the floor for questions on all of these first group of speakers. So if you want to wave your placard in the air, I will just ask that you keep it relatively brief, since we're a little bit over on time. And also, just to remind yourself, please do mention who you are and where you're coming from when you ask your question. And Dr. Marks, you happen to be right in my vision there, so you get to go first.
Thanks. So thanks for everyone for very nice talks. A quick comment and a quick question for Jose. I guess I know I always seem like the skeptical one in the room. I think there have been many, many mHealth interventions in many, many spheres of medicine, in HIV, in TB, in non-communicable diseases, and we often find that people really like using an app, but actually showing that that translates into meaningful differences has proven very, very difficult, and many things that seem to work don't actually work at a program scale. So at some point, we have to transition to robust, randomized evaluations of if any of these interventions do something. So that's, I guess, a comment. And I guess my question for Jose is just about the consent process for patients whose photos are being put into the database. So, I mean, for example, I have lots of photos of patients, but they haven't necessarily consented for their images to be used in an artificial intelligence app. So what is the sort of ethics and governance framework around the collection of those images?
Yes, thank you, Michael. Well, we have sorted that out with our Department of Legal Affairs. Any person or any institution donating photographs to WHO has to sign an agreement where all these aspects are taken into consideration, that consent is available, and so that there are no legal issues. Another very important, I think, consideration is that we feel there is a difference between a photo like that one that we see there, where that person can be recognized, can be identified, compared to an algorithm where the photo is only used by a computer but is not made public. But in any case, this is addressed in the agreement that we signed. So whoever is not confident that has the right consent to share the photos with us, we also don't accept them.
Great, thank you. And I saw a question right over there, although hand is down now. There you are. Yes, go right ahead.
Je vous remercie.
Thank you very much. I am a dermatologist and a coordinator of a program here. I wanted to quickly suggest something. I appreciate all of these presentations because they enable us to move forward, but I want to know what we're doing to help countries to train more dermatologists. Because if a country has more dermatologists, I think it is a long-lasting solution and it will help us to move forward further. So it is a good idea to share these applications, but we also need to help countries to train doctors because this type of training costs quite a lot and a lot of young people cannot access training. Second concern is regarding continuous professional development, CPD. Because once someone has a certain amount of knowledge, they don't know their limits. And this is something we have found in our teledermatology project in Congo, because they believe they identify all of the pathologies that they identify, and they associate them with those pathologies that they know. But it's far more complicated than that. So we need CPD to enable dermatologists to correctly identify the different pathologies and to create a framework and structure it. So we don't want them to identify anything as an NMT. We also need to look at the quality of photos because the diagnosis depends on the quality of the photos. In our project, we have provided a lot of information on the quality of photos so that we can ensure that that quality is achieved. Thank you very much.
Thank you so much for those questions. There's actually 3 questions in there, but Claire, I'm going to have you address the first question. I'm just going to paraphrase because I know the challenge here, which is that the first question was really, what are we doing to train more dermatologists? So, the question beyond just the availability of these apps, but what are we actually doing to train more dermatologists on the ground?
So I think that is an initiative for the dermatological community, the International League of Dermatological Societies, and expanding training programs. And they're going on all the time. And that is continuing to be an emphasis. But I don't think it's relevant for this particular delivery of service, but it is something that we are continuing.
Great. And then the next question, Dr. Prosigo, you want to answer that next one? Go ahead.
Yes, I would like to add that exactly there are efforts being made to train more dermatologists, Gloderm, what Claire just said. But here the tricky point is what Michael Marks said yesterday. What we need to train is more colleagues on dermatology. We cannot address the problem. We will never have thousands of dermatologists. We need to have general practitioners, nurses trained in dermatology.
And I would just point the questioner as well, I think we brought up a great point about quality of photos. And as we mentioned, there's a great poster today about photo quality. So just to point people towards that resource. Open for our next question. Go ahead.
Murad Moukni, from dermatologist from Tunisia. It's a short comment. I think these apps, artificial intelligence will be a very, very good tool. I think, thank you very much for developing such tools. But I think the most successful ones will be who focus not only on neglected tropical disease, on general dermatology, because we are looking that the main challenge is there is a mixture of basic and other dermatoses with neglected tropical disease. That means the most successful apps will be in the future who emphasize on. But the best dermatologists in the world, the best artificial intelligence will be faced, it will be always only a clinical. And there is a limitation for the clinical diagnosis. That means the development of these apps with a point-of-care test, I think both of them will have the perfect diagnosis in the world. It will be not maybe a good news for our profession as dermatologists, but it will be very good for the public health. Thank you very much.
Yes, just to quickly react on what Dr. Murad said. Yeah, from WHO, we are currently in dialogue with 3 private companies that have developed apps that are already available in the market on common skin diseases, and we are exploring ways of signing an agreement so that the WHO app can also provide diagnose or tentative diagnosis on common skin diseases. It's on the way.
Dr. Kaloga, did you have something you wanted to respond?
Merci à vous.
Thank you. I think my concern has been taken into account. As a dermatologist, we intervene in training schools and in the training of nurses in FAS. We could make the most out of the training we provide to also train the dermatologists that work on the ground. It would help us to train those nurses to go on to the ground to have a base knowledge to be able to better identify these NTDs. So I think at our level in our country, we're going to look at how we can work with the ministry to integrate that into nurse training programs. We think this would be a good idea to better roll it out across the country and roll it down to a lower level. So we're going to look into this idea. Thank you.
Thank you. I think we just have time for one last question over here. Yep, and this will be our last question for this session. Go ahead.
Merci, Docteur.
Thank you. My name is Dr. Raphael. I am the focal point at TVD in Côte d'Ivoire. In Dr. Yotsu's presentation, in the concluding slides, we saw a mycetomas picture. This came from Côte d'Ivoire. Did it come rather from Côte d'Ivoire, or is it just to give context? If it came from Côte d'Ivoire, do we have all of the references? Has the village been investigated if this case came from that Côte d'Ivoire village? Thank you.
Yes, thank you for the question. And yes, the photographs that I had on my slides are all from Côte d'Ivoire. So this is also awareness that these diseases exist in Côte d'Ivoire. And I'm happy to share with you the information. And we do have, we document the clinical and also the GPS data is everything is there for these cases. And so we are happy to share. Thank you.
Thank you. And with that, we're going to close this session for questions. We've been asked to have everybody stand up and do a short stretch because we know it's a lot of sitting, and unfortunately we can't take a full break. So we're going to have everyone for 20 seconds stand up, stretch your arms up. Here we go. Lovely. All right. Thank you, everyone.
Is it now the DG's thing?
All right, lovely. Thank you. Oh, this is my big chance to use the gavel. Here we go. All right, everyone. Beautiful job stretching. I feel we're all limbered up and ready to go. Perfect. So next up, I am delighted to welcome Michelle Murdoch, who will be talking about training tools for integrated management of wounds and lymphedema for skin NTDs.
Well, good morning, everyone, and I hope you're all awake after that great stretch. Thank you to Dr. Kingsley Asiedu and his team for inviting me and for organising this landmark meeting. And thank you too to Claire for such a masterful keynote presentation and for setting the scene so well for today's morning session. These are my co-authors for this presentation, and we're a mixture of people from the NNN Skin Cross-Cutting Group, as well as from the DMDI, Diseases Management, Disability and Inclusion Cross-Cutting Group. So if you like, we're a sort of cross-cutting group, just to confuse you. I have a single disclosure. Next slide, please. I am co-editor of a teaching journal called Community Skin Health, but have no financial interest. So as background to today's talk, as you've already heard from Claire, the Skin Cross-Cutting Group has been exploring various forms of training tools for community health workers. Then during the annual NNN conference in Kathmandu last year, we had a Skin Cross-Cutting Group meeting, and for the second half, we invited speakers from the DMDI group to talk about wounds. And this led us to discuss more about how this is an important potential area for integration of skin NTDs. And within the new strategic framework for skin NTDs, wounds and lymphedema management are considered together as sometimes these conditions can coexist in one disease. So we started asking what information is already available for frontline healthcare workers for the management of wounds and lymphedema in skin NTDs. So we started a scoping review to try and find out more, which I'll talk about today. And with regard to the future, we proposed that this might facilitate the generation of a compendium of resources and perhaps lead to the creation of some further generic training resource for wider adaptation and use. Next slide, please. Thank you. This was a relatively informal scoping review. We didn't have the time or manpower available to perform a formal systematic review or meta-analysis, but if anyone is interested in taking this forward, then you are very welcome to come and join us because, as you saw, we are a small group. With the help of the Royal Society of Medicine Library, we developed a search strategy using three main concepts. Firstly, neglected disease or diseases or neglected tropical diseases as a general term. For information, the term skin NTDs or skin-related NTDs is not yet a recognized medical subject heading or mesh term within Medline, but maybe that will change in the future. So we used neglected tropical diseases or neglected diseases as a broad term, or for each of the specific disease names. And secondly, we used wounds, skin ulcers, or lymphedema. And thirdly, education, teaching, or training. And the mesh heading, education, had to be exploded in order to pick up the terms teaching and training. The Medline, Embase, and Cochrane library databases were searched for these terms in the title, in the abstract, and the author keywords fields of reference. The search parameters were filtered to the past 10 years, only human studies, and we included all languages and abstracts from conferences. We also did a single Google search on one day, just using the string of online training materials and wounds and skin-related neglected tropical diseases. And the second part of the scoping survey was to send out a questionnaire to contacts, asking people whether they had any resources that they were able to share with us. And this survey went out to all the members of the skin and the DMDI cross-cutting groups. And in addition, Kingsley and Stephanie here in the WHO department very kindly agreed to forward that survey to some of their known contacts. Our inclusion criteria were very broad. We were looking for any training resource for wounds and or lymphedema, secondary to a skin NTD, or secondary to a general skin condition, but suitable for use in low-resource settings. Secondly, we also included studies which had utilized training for wounds and or lymphedema, secondary to a skin NTD or general skin conditions, etc., so long as there was good information within the body of the article about the detail of the training or within its references. So we didn't systematically look at all the references of all the articles, but if the article clearly provided a reference to the training, then we looked that up as well. 2 people assessed the records for eligibility and entered some key information about the resource onto a spreadsheet. This results flowchart shows our preliminary data. The 2 top boxes on your left are from the literature search, and the top 2 on the right from the skin NTD community contacts. After removal of duplicates, there were 496 records. We were unable to retrieve 8, which left 488 records. 261 were deemed ineligible, which left 227 records included in the review. This picture collage is not by any means complete, but it just shows some examples simply to give you a feel of what I'm calling some of the giants of training materials over the years, mainly published by WHO, and to which many people in this meeting have likely contributed. On the left side of the screen, we've got a couple of the lymphatic filariasis documents. We've got leprosy documents and Buruli ulcer documents. In addition to these disease-specific tools, we have some more generic ones with the Linda Lehman Holistic 10 Steps for Wounds. And over on the far right of the slide, we have general wound and lymphedema management with an updated version at the bottom of the slide there in 2021. And also at the bottom of the slide, that blue book on both leprosy and Buruli ulcer, a practical guide, was published last year, but that's not free. And of course, we have full integration of NTDs in the Recognizing Neglected Tropical Diseases Through Changes in the Skin handbook and in the WHO Skin NTD app, which we've just been hearing about earlier. So as you might expect, there's been a bit of a trend towards more integrated materials over the past recent years. This table shows the breakdown of the resources. There were a total of 227 records in the review, and approximately half of the items were open access articles. Separately, there were 28 books or booklets, some of which were quite lengthy, some were over 100 pages, but mainly freely available. The category listed as Other contained oddments like posters or fact sheets, and some of which were shared directly by the contacts. The teaching journal, Community Skin Health, which is freely available in hard copy, online, and as an app, had 13 teaching articles directly relevant to our topic. There were the 12 open WHO online training courses. We had 8 PowerPoint presentations, some of which were personally shared by the NTD contacts. There were 4 apps that we've been aware of so far and are freely available to the public: the Skin app from NLR, the WHO Skin NTDs app, Visual DX, which charges a fee, and Cyberderm, which is free, but you need to register to use it with a university institutional base. I would just like to mention 4 themes that we identified. Firstly, integrated training. Now, we didn't specifically search for integrated training, but 44 sources included training for 2 or more skin NTDs, which is encouraging. A second theme is that some good resources, such as PowerPoint presentations, were offline. And although the numbers here at 14 were small, we wouldn't have known about them unless the contacts had shared them with us, which highlights the need, again, for a communal collection of materials. A third theme, and I'm sorry it's not on the slide, was whether training was included for general skin conditions, and there were 74 records that did include this. And a fourth theme, again not on the slide, is assessment of training. Assessment can be of the trainee, or assessment of the training on the impact on the health of the community. Trainee assessments can be formative, such as when the trainee takes a test pre and post the training process and learns by feedback. or they can be summative, whereby it's like passing a test which has a certain pass mark. And there were 42 records that included some form of assessment of training, and this was all mainly formative. Dr. Postigo's open WHO online courses are the only examples we've found so far of a summative assessment, in that you have to get at least 80% of the quiz correct at the end of the course before you can get your certificate. The main challenges were that there were so many different resources in different locations. And also, there is still a relative minority of items that included any form of assessment of training. To conclude, ideally, we would like to look forward to a single location where we can find all of our skin NTD training tools. The Open WHO channel is leading the way for online courses. The Info NTD website and the ILEP websites are both easy to use, and they also have links to the WHO training tools. As I've said, a minority of studies included assessment of training. And also, on reflection, there was a lack of detail about care of wounds in the literature. My colleague, Dr. Hubert Vunat, will be talking more about the practicalities of caring for wounds and a suitable wound kit for use in low-resource settings during our session on Thursday afternoon. So I encourage you all to look forward to that. And in addition to needing to ensure that programs have availability of consumables for wound dressings, we also need to remember that we need to include assessment of the infrastructure of the health facilities to ensure that they're fit for purpose for wound dressings. Assessment of health centres is already quite a common practice in the package of care for lymphatic filariasis in some areas. There were also some potentially other useful areas of further work which we haven't pursued at all yet, such as wound assessment scales. Another one is wound-specific stigma and well-being scores. We came across one called Wound Q. The Wound Q tool is specific for wounds, and we've written to the author and obtained this. It hasn't been field tested in low resource settings, and that might be interesting to do. And traditional medicines for wounds was something that kept cropping up in the literature, and that's another huge topic for another day. In a couple of weeks' time, the DMDI group have their spring meeting in the UK, and Hubert and I will be joining them to discuss how to move forward the work on wounds.
Great. I'll just ask you to wrap up, please.
So our take-home messages are that rather similar to the established lymphatic filariasis package of care, we need to perhaps review and consolidate and develop a wound package of care. In addition to thinking about effective delivery of wound dressing consumables, we should include assessment of health facilities to ensure that they have adequate washing facilities for wounds. Water that is fit for drinking is suitable for cleaning ulcers. I've said that we need to include assessment of training, and I'm rather fond of short, pithy messaging for wounds, not only for staff, but also for patients. For example, clean more, disinfect less. If you use too much antiseptic, this can inhibit new epithelial growth. Another one is you need to treat the whole patient, not the hole in the patient, just remembering what else is going on and to think about, for example, the nutritional status of the patient.
Great. Thank you so much, Dr. Murdoch, for this excellent talk. Well, we're going to have to move on to our next speaker, but a huge thank you for this wonderful talk. So next up, we have Wenda McGuigan Yeshan, who will be talking about a hybrid approach of machine learning and clinical decision support for improved diagnosis of neglected tropical diseases. And with that, I will open it up to our friend Wende, who will be discussing about his work and experience in Ethiopia and beyond. And I'm keeping us on time for a reason, which is that the Director General is going to be coming at the end of this session, and I think it might be somewhat intimidating to our last speaker to be mid-talk when he appears. So, Wende, I'll ask you to do your best to stay on time. 1 second. And Dr. Murdoch, I'll just say a thank you to you while we're waiting for Wendy's slides to come up. I think so important to do that review work and so difficult to find all of those online tools. We're actually going to just keep it closed for the moment, but just so important to keep those, to think about the involvement of really searching about what's out there, and also, as you mentioned, things that are offline as well.
Did we lose the presentation?
Yeah. And Wendy, if you actually want to start by introducing yourself.
Yes.
Thank you.
So this is Professor Wenda McGuigan from Ethiopia. But today I'll be presenting actually a work I'm doing for consulting for visual diagnosis. That's as a disclosure. It has nothing to do with my base university, Bahardar University. So. Next. Okay. So the title of my presentation will be a hybrid approach of machine learning and clinical decision support for improved diagnosis of NTD. This is a project supported by Bill and Melinda Gates Foundation and done by the visual diagnosis. So the presentation will be next. The presentation outline will be, I'll have some introduction about the company and the experience in low resource setting, and the new project we are having and leveraging this, the AI technology for NTD. So just as introduction, the Visual Diagnosis is a company which has been working in the US for the last at least 22 years. That means the company have an experience of 22 years collecting images for skin diseases and other diseases, actually internal manifestation of, or dermatologic manifestation of internal medicine, ENT, and the eye, the ophthalmology, and others. So other results, recent assessment has shown that actually it has more than 100,000 images. That's why it has been called the world's best curated medical image library. And one interesting thing is, you know that just cutaneous pathology appears significantly different on disparate skin tones. As a professor of dermatology, one thing which will frustrate me in my teaching residents is that when my resident comes with the erythema, the word erythema or erythroderma, usually this is a manifestation you don't see in dark-skinned individuals, but if you see most of the classic textbook of dermatology, that's actually the big presentation of most of inflammatory skin conditions. So that means mostly those cutaneous presentation, they present differently in a different skin tone. So publication from 2020 from the Journal of the American Academy of Dermatology reported the assessment of 8 commonly used resources in dermatology. These are 6 textbooks and 2 web-based resources, and 65 conditions were selected for review. For each condition, image were categorized as light skin with to dark skin image and with the Fitzpatrick classification 1 to 6. And they have looked into around 15,000 images. Surprisingly, the published textbook, they are less representative for dark skin individual. Less than 10% do have an image of dark skin individual. The online resources, they have more of just dark skin, but the visual diagnosis has represented around 28% of its images are dark skin individual, and that makes it actually one of the leading skin color atlas. And the other thing is about the app. It can be presented in the mobile app, laptop, and tablets, and it's a smart search for chief complaint, especially the Diagnose app can be used in the PC, mobile phone, and you can enter a chief complaint to search the diagnosis and also the recommendation and the laboratory investigations, or you can search on the diagnosis to look into the recommendation, have a patient information sheet, plus also the other pictures, similar pictures, or you can enter also the drug reactions and so on. And the other thing is about the custom patient-specific diagnosis. On this app, one of the important things is when you look at it, you can you can customize your entry based on the patient demographic presentation. For example, if you based on dark skin, white skin, the geographic distribution of diseases and patient clinical presentation and configuration of the skin lesion and distribution of the skin lesion in the different body parts. And what we have found is the tool can also improve patient engagement and satisfaction, especially because it has most of the disease has patient information sheets. Plus also it can show some patients on similar, it can show the patients on similar skin diseases, and it can support clinicians and patients through the diagnostic journey by improving the patient satisfaction. So, next. One of the projects which was almost in conclusion was the mobile clinical decision support limited resource in Botswana. In the last 20 years, visual diagnosis has been working based in US only, and recently they have actually started to work in some of African countries. Next. So in general, when we see the access, the front line of the healthcare system in Botswana often consists of clinicians working in area with reliable internet connections and with limited training, dermatology and other specialties. So there is a lack of sufficient reference material that are available offline and easy access at the point of care that can help with the diagnosis and management. So the solution which visual diagnosis has come is with creating a mobile app which can work both online and offline. Next, for those health workers. And the key finding from this offline and online decision support system is that in the end of the project, in the assessment, they found that around 95% of respondents say that visual diagnosis improved the ability to manage dermatologic conditions. Around 89.5% of respondents said that the visual diagnosis improved their ability to make accurate diagnosis and has made their work easier. These are nurses and primary health physicians. And the providers use visual diagnosis and educational tool also, both for themselves and for patients also. And around 81% of individuals use the visual diagnosis outside of work as a study resource. And it has a resource actually about introduction in dermatologic diseases. And 84% of say that the use of the tool helped educate patients and build patient trust. In general, from what we have got, some of the comment from the participant is visual diagnosis doesn't only give you the condition, it gets all the way to image and training, so you can really rely on it. It can I can recommend it around just 100%. Next. So the other new project which we have launched is in December 2022 is the on visual diagnosis, working with the Indian NGO CARE and also with the Nigerian partners on identifying skin diseases and artificial intelligence. Next. So this project is going on in India. It's development of prototype clinical decision support and surveillance tool focused on only post-callosal dermal leishmaniasis. So using the visual diagnosis tool to remove existing barriers by enabling healthcare workers to evaluate skin lesions and symptoms, understand diagnosis possibilities, learn about the disease, and obtain guidance on the next step for the clinical testing and treatment. From the Nigerian collaborators, what we are doing is the Nigerian collaborators are going to the field and with collecting images from patients actually, and development of prototype clinical decision support and surveillance tool focused on image collection and machine learning algorithm analysis, optimization for selection of NTD in Nigeria. The exception about this project is usually the images are collected by the patients themselves in their own smartphone, and mostly the quality of the image doesn't matter here. And this prototype clinical decision support system will identify representative images of NTDs. We're working with 7 NTDs presentation and utilize this image to train the machine learning algorithm for image analysis to distinguish between NTDs and the NTD mimics. And in addition to this, we are collecting also images from different African countries and Southeast Asia in improving the machine learning. Next. So in conclusion, in conclusion, the project aims to meet the goal of the WHO Skin NTD mobile apps by supporting broad differential diagnosis for primary health workers. This is because of the experience we have on other skin diseases. And ultimately, this clinical decision support tool will be designed to be extensible, fitting local disease epidemiology, supporting improved diagnosis in countries beyond Nigeria and India. And next. I think this is all what I have. Thank you.
Thank you so much, Wende, and I think it's so important as we think about Visual DX as one group and app that has done such a great job with the machine learning and with really being interactive and being something so powerful in people's pockets. So I think so much overlap in terms of prior experience with apps and other apps that are being used and the algorithm that Visual DX uses, and it's just wonderful to see it kind of spreading across other areas as well. So with that, we're going to be moving on to Royce Gutjes, who will be talking about info.ntd.org, capacity strengthening for researchers and other health professionals through an online portal. And we'll be pulling up her presentation in a moment. Perfect.
Thank you. Hi, everyone. My name is Royce Gutjes, and I'm going to present on Info NTD today. Yeah? Oh, yeah. Yeah, okay. Next, please. Universal health coverage means that all people can access quality essential health services without having to suffer financial hardship to pay for healthcare, according to the World Health Organization. There will still be a shortage of 10 million health workers by 2033, particularly in WHO African and Eastern Mediterranean regions. This shortage needs to be overcome by using modernized methods for capacity strengthening, supporting health workers in providing an integrated, holistic approach. Next, please. Info NTD is an online platform that supports capacity strengthening for NTD professionals by making cross-cutting NTD information easily and freely accessible. The platform is supported by partners from within the NTD sector and managed by NLR. Next, please. So we function like PubMed, focused on cross-cutting issues in NTDs only, and we offer additional services such as free full-text delivery when a resource is not freely available, and a monthly newsletter sharing the new NTD evidence and tools, ensuring that all NTD information is easily accessible for all. In 2022, the portal was visited by 43,000 unique website visitors from 200 countries. So most of our visitors are from Asia and Africa. So it's amazing to see that so many people are finding their way to the portal. We provide easy access to 6,000 resources. Next, please. Next, please. Yeah. So this is a screenshot from the homepage. On top you will find the menu, and at the bottom you will see a search bar that facilitates searching for NTD resources. The portal used to share mostly scientific papers. Meanwhile, several toolkits have been added, and you will find an overview of NTD organizations. So we held an online survey to learn more about the user experience from our audience. So it was set out, we recruited people through the Info NTD portal via a pop-up, the newsletter and email, and the respondents were Info NTD users and people from the NTD community. It was set out during November 2021 and January 2022, and there were 18 questions. Some were open, some were closed, and some were multiple choice. There were 73 participants, of which 38% work for an NGO, 38% work for an academic institution, and 8% for the government. The NTDs that people work with varied, but mostly mentioned were leprosy, 44%, lymphatic filariasis, 44%, onco, 27%, and schisto, 23%. Next, please. Overall, respondents are interested in accessing different types of practical materials, but indicated to be especially interested in how-to, guidelines, and online courses. Next, please. So the topics of interest for practical materials also widely varied, as you can see. But the top three cross-cutting issues of interest were health system strengthening, stigma and mental well-being, and skin NTDs. Next also. Yes, and next please. Using the outcome of the survey, we have developed a new functionality. As you can see, an extra menu has been added on top. It's practical materials, and also at the bottom, at the home page, you will find the latest practical materials. So we now enable easy access also to practical materials, such as training guides, online courses, podcasts, apps, and more. We're very excited that it has been launched last week. And this is the first prototype online, and in the next couple of weeks we will further optimize the tool and add more resources to it. But please feel free to have a look and to let us know if you have any suggestions. Last year we also implemented, next please. So here you will see an overview of this new search functionality for practical resources. Last year we also implemented the Boolean search functionality, so you can use that as a method. So we do not create any online courses ourselves, but with this database we would like to encourage you to see what's already out there and see what can be reused and to promote cross-cutting approaches. Yes, so here are some of the tools that we have already added. The NLR skin games, the WASH and NTD coordination online course from the Ministry of Health Ethiopia, NALA Foundation and Sightsavers, the Community Health Good Practice Guide from CBM, the WHO Skin NTDs app, Rehab, an app that provides free information on rehabilitation by enablement. And we also link to other platforms such as Kikundi. So what's next? Well, we received so much positive feedback and the number of users keep growing. So we now want to see how we can take it to the next level. In the upcoming weeks, we will further optimize the practical materials database, adding more resources to it and also officially launch it. And we will further optimize the website navigation to ensure that all visitors can easily access the information that they are looking for. For example, the search menus will get a clear description on how they can be used. Innovate, we're currently looking into the possibility of artificial intelligence and how this may be able to support us in science communication and working even more efficiently. And we're also discussing, maybe doing a pilot by asking researchers to upload a short video and briefly explain lessons learned and practical recommendations to enable science communication. To collaborate, we also, of course, are in touch with other NTD organizations such as iLab, the NNN and iCourts to streamline our work and collaborate whenever possible. For example, InfoNTD will launch the NTD Inclusion Scorecard later this year, which is a tool that is developed by iLab and NNN to increase the participation of persons affected by NTDs within NTD organizations. Next, please. And community. How can we further contribute to the NTD community? Especially for the practical materials, we're looking into implementing a rating or reviewing section to facilitate sharing lessons learned. And how can we implement a feedback loop so that users can directly feedback us that we can incorporate and also be responsive to our audience. Next, please. Well, we have shared some ideas, but of course we are very interested also in hearing your ideas. So if any ideas came up, please don't hesitate to share these with us via info@infontd.org. We also recently added a Skin NTD's content page, linking tools, publications, and organizations related to Skin NTDs. Let us know if you wish to add a tool, publication, or organization to this page. And we also have the organizations menu that can be used to easily find organizations within the NTD community. Next, please. And yes, this is a call to you all to share practical Skin NTD materials with us. We can link to these on your website or upload the materials to our website. And yeah, already some great examples were shared this morning. So of course, we would be glad to add these if they are not already there. So any training materials, guidelines, online courses, checklists, apps, database, podcasts, anything is welcome. We would be glad to link to these. Next, please. So by sharing work that's being done, lessons learned, and making information easily accessible, we will all contribute to further strengthening of health capacity. Thank you very much.
Thank you very much, Dr. Gutierrez. And I see some wonderful synergies with Dr. Murdoch's excellent presentation in your work as well, and thinking about how do we share and collaborate with these resources that are strong but often in disparate locations and have to be spent so much time searched for, and then you have this wonderful place where you have this beautiful repository for all of these resources. So I think such a wonderful synergy as I think about all the different tools that have been shared this morning between the different speakers. So with that, we are going to move on to our final speaker of this morning. We'll be talking to Dr. Bahadir Selikatmer about enhancing leprosy expertise, a new leprosy competencies.
Hello, thank you. And I'm very much aware I'm the last person standing between you and your lunch, and of course the photo ops. I'll fly through this presentation. Like many of you are aware in the room, there's a big expertise shortage, skills shortage in the area of leprosy and also other NTDs. And at the Leprosy Mission, we're also seeing that as our more experienced staff retire, it's becoming more and more difficult to recruit the right people with the right expertise and skills. And we work in over 25 countries. We have more than 1,500 staff working across these countries. And when I'm talking about staff, I talk about people who work in the office, in fundraising, in programs, in the communities, doing hands-on work at the hospitals, clinical work. We have researchers, we have labs, and we have people working in parliamentary corridors. So we decided, in light of this, this challenge, we decided to map out the expertise needed to work across all these areas. And next slide, please. And we came up with this leprosy competency tool. This is something we developed for our own organization, obviously, but we will hope that this will inform national leprosy programs, and also other NTD programs and organizations. So what you see here is 10 competency areas. Control, diagnosis, treatment, lab skills, nerve function, reactions, wounds and ulcers, eye complications, mental health and well-being, and social aspects. And in all of these, in each of these competency areas, we have identified 4 levels that people, our staff, should have expertise in. So these are foundation level, basic level, intermediate, and then advanced or specialist level. And all our staff are going to be placed in one of these levels in all these competency areas, and this will be done at the national country office level. What you see on the right side is we are embedding these competencies
into people's role profiles. So we're doing this, it's almost like a partnership with our programs and HR teams. So when a person is recruited into a role or in an existing role, their role is assessed against this framework. Then their skills and knowledge are assessed against the role requirements, and gaps are identified. And based on those gaps, every staff member in the organization will have a tailor-made personal, professional development plan in place. Next, please. I just want to quickly show you what this looks like, what these levels and competencies, skills required looks like. And this is the foundation level, which is about demonstrating understanding of leprosy. This is our first, as I said, foundation, basic level. People who are answering the phones at any place in the organization, not necessarily patient or service user facing roles, will be looking into these, knowing the basic facts about leprosy, has removed all taboos around leprosy, knows the prevalent myths about leprosy, knows where to find help about leprosy, and can signpost accordingly. Next, please. And there is the next level is basic. It's not about. It's now more about applying that understanding of leprosy. So understanding how their own role contributes to defeat and transformation of individuals and communities affected by leprosy. There's a basic understanding of the causes and consequences of leprosy. We're talking about reservoirs, treatment, nerve involvement, reaction, self-care, and so on. And UN principles and guidelines for the elimination of discrimination against people affected by leprosy, and so on. Next, please. Next, please. I'll just skip this. Okay, so this is a sample roles and skills, knowledge and skills assessment for a field role. So what we see is basic, intermediate, and advanced roles. Let's just focus on one. Let's look at the intermediate level in the sample field role. The knowledge required from this person is knowledge on diagnostic procedures, on cardinal signs of leprosy, skin assessment, nerve assessment, WHO disability grading and EHF scores, differential diagnosis, we're talking about skin and nerves, reporting procedures, risk factors, and awareness that leprosy also has an impact on mental health. So this is a knowledge, but the skills follow. So we're talking about identifying common presentations, suspecting leprosy in atypical cases, recording and reporting appropriately, training others to suspect leprosy, communication skills to sensitize and enable a person to avail treatment, education of patients, listening skills, soft skills have been mentioned earlier in the room, and ability to refer to mental health support. Next, please. And this is a sample assessment tool. Of course, it's much more detailed in practice, but I just wanted to show you what the levels expected look like from, let's say, from hospital physiotherapists, a vocational training center manager, and leprosy control officer. In all these different 10 competencies, what levels are required from each role is summarized there. Next, please. Brilliant. So we also started thinking about, if we are going to embed this into the organization, how are we actually going to do that? There are many ways to do that. We have decided that the question of who should do the assessment, line managers at this point will be doing the assessment with the people who work with them. We are also preparing a toolkit to avoid bias in the assessment, because we're talking about 25 countries, and it's very important that when we're assessing skills, we're assessing the same thing at the same level. And we are also in the process of training, developing training materials. So training videos mostly for the basic level, but we're also using communities of practice, mentoring, shadowing, exchange visits between different countries. The key here is we don't want to rely too much on one-off training for these skills, because we find them limited in, for the purposes of deep learning and sustaining that learning. And as I said earlier, we're also integrating this whole competency framework with our HR system, and we're including this into the HR performance management cycle. There are many different ways of doing this. Probably this is how we are going to do it. Next slide, please. And this is the last slide. So what's next? We were quite ambitious to suggest that we would complete the pilot in 2023. It will probably be later next year, but we're in the process of the pilot. We're working in Nepal, Nigeria, and England and Wales to trial this. And we're also working closely with ILEP's LIFT Leprosy Learning Project to ensure that what we're producing results in coordination and development of joint training with other leprosy organizations and ILEP members. We are looking at, as I said in the beginning, we would really like this to inform leprosy programs and other NTD organizations. So we're starting a pilot later this year with the Leprosy Mission Mozambique, where they will use this competency tool to work with the health district departments and workers. So it will be very interesting to see whether this actually has any currency in the national leprosy program. And I think that's it. I wanted to fly through this before lunch, and yes, thank you very much. It's very, I would very much like to hear if there are other organizations in the room focusing on other NTDs. If you have something similar, or if you'd like to do something similar, I would very much like to hear from you, because we're talking about integration here. Perhaps this could be just one NTD in a portfolio of NTDs that we could be talking about. Thank you very much.
Well, thank you so much, and we very much appreciate your timeliness right before lunch. We have just about 2 minutes, and then we're going to be going outside to gather. I just wanted to, since we had to shorten your presentation very briefly, I think you had one last thing you wanted to share with us at the very end, so please go ahead.
Thank you, Esther. Yes, really, just to say that this work is not finished, and if you haven't received our survey, it's not too late. So please contact me if you've got any training materials that you'd like to share. Thank you.
So what we're going to ask at this point, and by the way, all of these discussions this morning, so important and so interesting, and I apologize that because of our photographic opportunity, we are going to have to move some of this discussion to online. So I would encourage you to go into the Zoom if you have any questions for our wonderful speakers this morning, because I think there's a lot of discussion to be had and a lot of wonderful training tools. With that being said, are we ready to move outside, Dr. Sose?
We can continue the discussion.
We can continue. Oh, great. Okay, we've been given a few extra minutes. Fantastic. And so I'm just going to warn you, logistics, which are not happening yet. We're actually going to stay and have a little bit of a discussion. But when the Director General does come, we are going to be moving outside to the stairs. We would request that you please leave the first 3 rows open unless you have been given a very specific assignment location, photo location sheet. So please make sure that you proceed your way up the stairs and leave those first 3 rows open for the photo assignments. That being said, we should make use of this time because here we are together with these wonderful speakers. So I'll open it to the floor if anyone has a question.
Apparently he's coming.
Oh, he's coming right now. Okay, never mind. I love this. I feel like I'm tap dancing up here. Okay. Do we want to?
He's asking where is the room, so he's in his way.
Do you want us to stay seated here while he comes in?
Yeah, he can sit and say hi.
Okay,
he can take
fantastic.
photos. Yeah,
we can, well, then why don't we open the floor to one short question. Yeah, I'll move over here. Yeah, I'm going to move over here.
No, you can,
here, I'm gonna move here.
You can sit. It's easier. You sit, I will move.
Yeah, no. Here we go. Here. I'll take his computer. There we go. Sorry, you're watching us all move around up here. Well, I'll just provide a quick summary then, since I know it's a little challenging to squish a question into this brief moment. So this morning, I think we were really delighted to hear a variety of presentations from a bunch of different countries, both about what training tools currently exist online in terms of mHealth and how artificial intelligence can potentially be used to forward this mission. I think we also heard some important challenges this morning about how do we handle things when there is no internet access. And also, I think some questions that were raised online about translation. Dr. Postigo's done a wonderful job of really having a lot of tools translated, but I think some of the issues are even beyond the WHO languages and the standard UN languages, but how do we handle translation into local dialects where there's a particular emphasis on, for example, conditions such as mycetoma being particularly common in places where languages may not be part of the standard UN languages. So I think some additional challenges for us raised there. I think some themes that we've seen gathered from this morning are around the challenges with collating existing opportunities and existing resources. So I think some of the presentations this morning have highlighted just the incredible work that's being done to bring together existing resources. And with that, I'm going to wrap up this morning's session and welcome the Director General of the WHO. Great. Well, thank you so much to the Director General for joining us today. It's really our honor to be here for the first ever WHO Global Meeting on Skin NTDs. And we have over 300 participants in person, and we have an additional over 300 online. So truly a global audience for this opportunity, and we're so appreciative that you could join us today.
Thank you, DG, for coming. This is really a very important meeting. And as you are aware, one of the strategic shifts in the NTD is really to make sure that we use cross-cutting approach and integration for more cost-effective and more practical service delivery at country level to improve the primary health care in the context of universal health coverage access. So this framework on integrated skin NTD approach is really part of the roadmap and will also highly contribute to access to services where they are most needed at the front line. And this morning session, we're just looking at innovation and technology to make sure that even people living in remote areas and health workers can have access to technology to be able to diagnose and treat the most common NTDs. So this is really a good way to show how NTDs should work together, but also outside, the NTDs. We have so many commonalities with so many other areas like, health security and emergencies, universal health coverage, primary health care, climate change, and so many others. So making sure that we use a cross-cutting avenue for more effectiveness in service delivery, but also for access to more resources will be critical in the future. Thank you for joining us.
Thank you. I think you want me to say something.
Yes.
No, by the way, I was invited to have a photo with you. Then my proposal would be better if I join you on Friday. That will be the closing, and when I can listen to your advice, your recommendations, and then have some engagement then, because I prefer two-way communication. But then Sose told me that some of our facilitators are leaving before Friday, so he suggested if we can have the photo today, and then he can come on Friday as well. So I will save the discussion or whatever I would like to say for Friday. After listening to, the outcome of your deliberations. I think that way I can also learn from you and also get the asks you have for me and support in any way possible to make progress in NTDs. When we lump sum the NTDs saying neglected tropical diseases, I think many people think that we're talking about few diseases and affecting few people, but it's not. Imagine just the skin entities alone, how many they are and the suffering they cause, and then bring the rest. It means they should not be neglected, and we need to really give them the right attention they need. So that's what I would like to underline, and look forward to listening to your summary of all the discussions and the recommendations, conclusions and recommendations, and some specific asks you might have for me. So look forward to also from my side do whatever I can to make progress and serve the people we serve in a better way. So with that, thank you so much. We can have the photo now and then the discussion on Friday.
Thank you, Didi. So, we are waiting for your instruction. The photograph?
So I think the plan is to go, are we proceeding outside to the stairs? Yes. So if everyone could please, in orderly fashion, stand up. I'll have you proceed to the stairs. Please leave the first 3 rows free. So if you are the first to reach the stairs, I know it's very tempting to stand towards the front, but please make your way up the stairs. We will all fit, and I'm going to open it. Stephanie, did you have or Priya, did you have a comment about, yes, Priya, go ahead.
That's okay. I request everyone to go in a queue towards the stairs like yesterday, and please, like Esther said, please leave the bottom 3 stairs empty. Thank you very much. I'll be there to help you out.